You can't know how to use ultrasound unless you have like a little introduction. And so this is like a basic knobology instructional class. And knobology is a real word. I just made it up, and it's probably already in the dictionary. Not really. As far as yesterday's exam goes, I know some of you were great, felt great about it. Some of you are a little frustrated. That's a really hard exam. Some of the surgery exams are hard too because you have to really clinically think and you have to have confidence, which we have destroyed during your tenure here at IPAS. So, kudos to you guys as a class. You did well overall, and I always do this because it didn't meet test committee criteria. I give back the 3 lowest performing questions to the people who need it the most, right? And so if you got a 96 on your exam and you're really upset about one question, I'm sorry. That's like a total first world problem. I'm not sympathetic, and I'm also not unwilling to say when I'm wrong or incorrect. But the lowest performing questions I take as a reflection of me, that I did not obviously teach that material well enough, or the STEM was too confusing. So everybody should get 3 questions back, unless you're one of those unlucky ones that always get the right answers, or the ones that are being given back. But anyway, there were 2 dual credits, 1 paying credit, so hopefully that'll help some of you. All right, any questions about that? Okay, moving on. I'm just kidding. Okay, so today we're going to start with ultrasound. Is anybody here excited about ultrasound training? Yeah. I am. Aren't you finally ready to get your hands on stuff? A couple things. We have 4 of these awesome machines. Kyle Johnson was able to secure these with seed funding, and they cost over 200 grand a piece. So as you can see from your grungy little classroom, that's an extraordinary feat that he accomplished. So we're going to take care of these. Don't drop the probes, please. We're going to wipe them off. I'm going to show you some basic ultrasound etiquette. These wipes are for the machine, not for each other. Okay, even has like a baby on it that says no, you can't put it on the baby. That means you too can't put it on you. But I'm going to show you some stuff. By show of hands, who here is pretty experienced at ultrasound? Would say that you feel pretty comfortable doing some stuff. You sure? EFAST? Any other stuff? MSK? Anybody else? You? You sure? Is it mostly EFAST, or have you used it in IVs? Okay, really a good tool. You in the back?
EFAST and like MSK for shoulders specifically.
Absolutely, MSK. And so this is part of your military unique curriculum. No other program is really incorporating this. I can't say no other program. There's a few that have reached out, and I've actually shared all my slides. I went up to South University up in Austin and taught them. They bought a bunch of machines. I taught them some stuff. So they're starting to try to incorporate some of the POCUS. But literally, since the invention of the stethoscope, this is the only other thing you can do right at the bedside that's going to give you power as a clinician to make decisions. And in a pre-hospital environment, it's going to give you power at roll 1 and roll 2. Do I evacuate this person? Is there pneumothorax? Is just a superficial wound? Is this a ruptured ectopic pregnancy? And I'm going to talk all about that. Okay, so you can't know how to do it until we know some basic knobology. So hopefully my little cool pointer works today. So this is Introduction to Point of Care Ultrasound, POCUS. All right, that's what POCUS is. So what do you think that means?
Point of care.
Yeah, it's right there at the bedside, right? So this isn't a comprehensive echocardiogram of someone's heart. They get that in cardiology, right? This is a great machine, but it's still maybe it's not a Bentley. Okay, the people in cardiology, they have a Bentley. All right, so it's still very nice. It's even nicer than the ones we use at BAMC. So we're going to talk about this. So I'm sure when you thought, oh, we're going to learn about ultrasound, you just automatically pictured babies in a womb. Okay, am I right? Anyone? Is that what you associate ultrasound with? At least that's how I grew up in medicine. Like, only people who are pregnant or specialized in some way get ultrasounds. But ultrasound has come a long ways. Okay, we've done a lot more great things with ultrasound now. So some of the things we're going to talk about is what those things are, how you're going to use them, and more importantly, we're going to teach you how to use them. We can only get good at ultrasound by doing reps. This isn't one of those things that you can just go read about and then go reproduce it and do the exam. You're going to have to put your hands on the probe, on each other, and practice. And I'm going to give you plenty of practice time in class to do it. So don't be screwing around. Unfortunately, there's only 4 of these good machines, 2 old ones, and you big groups of 10-ish, right? So we take turns. One person's a patient. We take turns in our little respective groups, and you are very proactive. Historically, other classes have come in at lunch. They've stayed after. They come in on the weekend before the test out because they're nervous about it. At the end of this lecture, I have handouts for all of you, little cheat sheets, which is going to be awesome. And then I also post the grading rubrics so you know exactly what the expectations are on test day, okay? And this is a pass-fail grade, meaning that if you fail the hands-on portion, you get one opportunity to retest with me, and if you still fail, unfortunately, you have to do a 50-question written exam, and it sucks. And that's what they used to do when Carrie Van Arnhem was here. She was an ultrasound fellow trained. She used to teach ultrasound, which is fantastic, but she taught it like you guys had to like calculate ejection fraction. It was like a little crazy, over the top. And so I want you guys to know some core things that are also like absolutely going to help you in your military career, or if you're in family medicine for the guards folks, okay? So basic physics, when you hear that word, you just want to tune me out, I don't blame you, but we're not talking like real physics, we're talking about just ultrasound machine stuff. And then knobology, like I said, I made that word up, I might have done it before today, but anyway. All right, so image evolution, what do you think this guy's doing? He's in a giant water bath, all right? That was like 1950s, and that's how the earliest medical ultrasound was used. You literally had to put somebody in a container, and it took 30 to 45 minutes of this, you know, lukewarm or cold water. So do you think any unstable patients were being thrown in there? Yeah, not a lot of big life decisions happening there, okay? And we've evolved to the point where, I swear, the initial ultrasound, when people were in these water baths, it bounced these echoes, also known as ultrasonic waves, off the patient, and then it kind of put little pixels on a screen, and that was how they interpreted it. Does anybody know what that, they're not correlating, but what's that image on the right? What do y'all think? It's really hard to make out, right? That's actually the outline of a baby. Okay, so again, the two things don't correlate. Obviously, that's not his baby. I mean, it could have. I guess it could have been his baby, but it's not. He's not with child. Okay, all right. This would go better if my, if they. I think there's a block here. I think they make you not be able to walk away. Anyway, so in early images, we're getting better and better with our imaging. The pixels are getting better to the point where now we can actually measure a crown rump length of a baby, and we know exactly how far along mom is as far as the pregnancy. So it's evolving. And embedded within the ultrasound machine are technologies. So I can actually pick, hey, I'm going to do the DVT ultrasound, and it will set me up on some presets with depth, maybe certain measurements, things like that, or ocular. It gives you some fetal, you know, abdominal, tart, all these little presets. The machines are really, really smart now as well, okay? All right, so again, image evolution, baby. Now there's even, most of the time when we do ultrasound here, this is two-dimensional, all right? We do two-dimensional. There's three-dimensional ultrasound that exists out there in the universe where they can actually see features of the baby so profoundly, and now they're even coming out with 4D images, all right? Pretty awesome stuff, but for all intents and purposes to date, bedside ultrasound POCUS is two-dimensional, okay? So not as fancy, but still pretty awesome. So literally when I worked in Brady, Texas, I was like, hold on, I'm gonna do an ultrasound on this person. I was like, where's the ultrasound machine? Because they told me they had one. And it literally was, it looked like a giant, like I got it, and I don't know if anybody saw me wheel this thing up. I mean, this is a pretty small portable, and I probably hit the tables and couldn't navigate this corner with this thing. So anyway, when I worked in Brady, Texas, they had this humongous machine that I couldn't even get into the exam room of the patient. I was like, I'm going to save the day and do this bedside ultrasound, and I couldn't even get the ultrasound machine in the door. Okay, so that's the original ones. So there was no life-saving happening by me that day, at least by bedside ultrasound. Now we have portable ones, and now it's even more portable where this little butterfly probe I plug into my cell phone, and I have a butterfly app on my phone that I pay for out of my own pocket, I promise, and then I have an ultrasound at the bedside. Have you guys ever seen those Sonosite commercials where like this blonde doctor dressed in a white coat is running onto the soccer field, and her hair is flowing like a Beyonce video, and she's like diagnosing fracture right there on the soccer field, and they evacuate the kid, and it's like kind of dramatic. But anyway, the truth is, it's so portable that now even some of the docs at BAMC will carry their little man packs and they actually have their own portable butterfly right there in their pocket. So pretty good stuff, right? And if you go to your units at roll 1 or 2, you should be fielded with a GE machine or maybe a butterfly of some sort. It should be fielded at every roll 1, 2, and of course roll 3 will have them. Okay, you guys know what I mean by roll 1, 2, and 3?
Yes.
Other branches, Air Force, you guys, be honest. Okay, sir.
How durable is the little pocket one that you have here?
It's pretty durable. I'm sorry.
You drop the probe, is it like pretty sharp?
I mean, it's kind of like my cell phone. I probably have dropped it a million times and it still works. But this is the first generation butterfly. And so what's interesting about these probes is that they have little special crystals in them. They're lead, zirconium, but they're called piezoelectric crystals. And so they can get disrupted. And so you'll see we have a couple of the older versions of sonocytes that are portable that we're going to be using. We used to have 6 of them. We're down to 2 because of that very thing. You know, so they're getting more and more durable, but they're still not completely soldier-proof, as you know. So here's a bunch of different uses for ultrasound, right? This is just bedside point-of-care ultrasound. So I'm trying to point with my pointer, but it's not helping me today. And okay, so ultrasound applications. So has anybody used ultrasound for any of these reasons in the past? Some of you said you did. Yeah? Okay, we talked about EFAS, we talked about MSK, we talked about vascular access. What about any of these other bedside utilities? Do you have to be an emergency medicine PA to do some of these things? No. Nerve blocks, if you're working in anesthesia, right, that's important. Or if you have somebody with an open fracture, right, it's very painful. Do you want to snow them, you know, systemically, especially if it's an elderly that fell? Probably not, but if you can do a nerve block, or especially if somebody has a flail chest, those things are very painful. You can do nerve blocks. You can use it as a measure of resuscitation. What did I tell you during block 2 that we can look at to see if the patient is fluid overload or fluid down? Look at the IVC. So it can actually be an endpoint of resuscitation. Instead of waiting for urine output, you can actually see how fat the IVC is. Anyway, confirm intubation, you know, all this stuff is what we can do at bedside. Literally every specialty except for psychiatry uses ultrasound now. That's pretty cool, right? And I'm sure they'll figure out a way to use it. I mean, I would. Okay, so moving on. So we already talked about comprehensive versus point of care. Comprehensive is like, you go to cardiology, you get an echocardiogram. Point of care is, we're at point of care, and in order to use it, we're gonna ask ourselves a clinical question. Like, we gotta know what we're looking for. We're not just gonna ultrasound everybody. Maybe initially, because it's fun, and maybe while you're here learning, it's fun, but we gotta have a clinical question. So when we're doing point of care ultrasound, we're asking something very specific. Do you guys agree? So the first thing we have to do is define our clinical question. So I'm gonna give you an example. Man witnessed cardiac arrest, all right? He's pre-hospital, witnessed, they're doing CPR, there's no pulse, they're continuing CPR at the house for 10 or 15 minutes, they're gonna transport him to BAMC, all right? So we at BAMC are like, trauma team to the trauma room, and so we're all in there and we're like, hey, man down, CPR in progress. So our clinical question is there cardiac activity? So why does that matter? Yeah, so if somebody doesn't have a pulse, but maybe the heart's trying to squeeze, we'll continue CPR, we'll continue running that code, right? But this person's been down 10 or 15 minutes, so they probably have an anoxic brain injury. So if they come in and the heart's not even trying to squeeze, it's futile for us to do it, and it's not safe or humane either because they're probably not doing well neurologically. Okay, so in this example, I'm gonna say we're gonna ask, my clinical question is there cardiac activity? So if that's my clinical question, then what image do I need to obtain, or image acquisition? Like, what is my best image? Well, I want to get a subxiphoid, and if I can't do a subxiphoid to see the heart because of whatever reason, bowel gas or whatever, then I'm going to do a peristernal long. I need to look at that heart, see if it's squeezing. Okay, does that make sense? Okay, then I'm going to have to look at the image and actually interpret it. Is there cardiac activity? Yes, no, right? And then lastly, make some sort of decision based on what I just did. You guys agree? So is there cardiac activity? Doing a subxiphoid view is my image acquisition. Yes, there was cardiac activity, so do I continue CPR? Yeah, I do. That was my clinical question. So yes, we're not going to stop it, we're going to continue. So ultrasound, by definition, is ultrasonic waves. Anybody know how ultrasound was invented or who invented ultrasound? Huh? So yeah, a lot of people want to credit the Navy, and it is the Navy, but it's not the US Navy, unfortunately. But what catastrophic event happened in the early 1900s that they are like, man, I really wish we had that kind of technology? The Titanic, the sinking of the Titanic, right? Oh, the iceberg, you couldn't see it, right? And so they had the technology, they were kind of using it, but they didn't really become mainstream on all the ships and stuff until after the Titanic sank. So that was a big uh-oh. So literally, it's ultrasonic waves bouncing out into the universe or into your patient, off hitting the tissues and then coming back to the transducer. And the lower the frequency down here, like your curvilinear probe, it's a low frequency probe, you get good penetration, but not really good resolution. Okay, the image isn't as clear because it's deeper. Does that make sense? Okay, whereas higher frequency probes, there's more and more contact with the ultrasound wave hitting the tissue and coming back to the probe, so it's real superficial, it's going fast, and so we get really good quality images, like your linear superficial probe. This is the one we use for vascular access, for nerve blocks, for ocular, for DVT in most patients. Some people have larger thighs and they have to go bigger. But anyway, this correlates. So what does ultrasound mean? It's sound, but with the ultra part. It's above our ability as humans to hear it, right? Okay, so ultrasonic. So normal audible sound for humans is somewhere between 20 and 20,000 hertz. Most ultrasounds are greater than 20,000 hertz, so it's above human hearing, okay? Maybe bats can hear it, but medical sound, ultrasound oftentimes is greater than 200,000 hertz, all right? So it's not torturing your puppies or anything at home if you happen to get one. So you may not be that familiar with ultrasound. Some of you are, some of you aren't, or the way it works, but it's kind of like a speaker. Anybody familiar with a speaker? Anybody have one of those giant boom boxes in their trunk like I did when I was in high school? That was cool? No? Okay, super cool. Okay, I just want you to know, no matter what you think, that was super cool. So, just like a speaker, it takes electricity out of the wall, puts it through the speaker, and then outputs audible sound. Well, even my mic is out. Wow, that's a sign. That's okay, we'll give it a minute or two. So that was a deep bass, loud enough for everybody to hear. I know my slides, so you got yours in front of you, right? So we can just keep going. Okay, so the lower the frequency, the higher the penetration. So to put it in perspective, it's almost like if you're at an apartment complex while you're here at IPAP and you're gonna go to this party and you already hear the bass just thumping like boom, boom, boom. That's all you hear, okay? You can't make out the sounds, the lyrics, the other instruments that's playing because those are high frequency sounds. All you hear is the bass, boom, boom. I usually act it out, but I have to have a microphone, okay? So it's not very fun. Anyway, so then when you finally get to the party, you open the door and you hear all the lyrics, all the other instruments. That's high frequency, okay? So that kind of puts it in perspective. So if we're looking at deep organs like kidney, liver, stuff like that, we usually use the curvilinear probes because that's our deep frequency probes. Okay, this is your curvilinear probe. You guys are with me on your slideshow? Okay, that's a curvilinear. So that's our deep penetrating stuff, and then I already said the linear one is what we use for superficial stuff. So we're coming back here. Still going to take a minute. So unlike a speaker, what happens with the ultrasound probe, these crystals in here not only transmit those ultrasound waves, but once it bounces off the tissue and comes back to the crystals, it actually interprets the depth and the images from that. Okay, so pretty good stuff. So that's the piezoelectric effect. All right, this should start back up in just a moment. Okay, so you should be on the slideshow photo where it shows all the transducer probes. Do you see all those? A whole bunch of them. All the ones to your left are considered curvilinear probes, all right? Those are, some of them are endocavitary probes. We used to call them transvaginal probes, but it got a little uncomfortable when we had to do like a peritonsillar abscess, for instance, okay? Nobody wants to have a peritonsillar abscess cut with a transvaginal probe. So we renamed them endocavitary, and they do use them for a number of reasons. We'll look, you know, sometimes in the rectum for hemorrhoids, but most of the time we do it for like women's health to confirm first trimester IUP, intrauterine pregnancy, things like that. Those are all those images on the left. including the ones that look like curvilinear. Then the ones in the middle are small. These are your phased array. They're kind of your middle of the road probes. And these are the ones that have better resolution than your deep curvilinear, but better penetration than these superficial linear ones. So it's kind of the middle of the road. And this is what most people that we do in trauma, this is what we use most of the time when we do our EFAST exams, because we can get in that subxiphoid area really easily in between the rib cage. We can actually maneuver it really well. The problem is we don't see as great as we would with the curvilinear because it doesn't go as deep, but you can still see everything that you need. Are you guys with me, or do you need a break? All right. It's the system, this step's not starting back up. It says call somebody, and I'm not doing that, so I'm just gonna keep moving on. Again, to the far right of your screen is all those linear probes. All right, those are your superficial parts. So name some things that we can do with the linear probe that we've already talked about. This guy. IV access, also I use it for central line access, okay, and the right IJ, okay, or it can be left, but usually right. What else? Ocular, good, what you're gonna have to learn how to do. DVT for most people. Again, if you have a big thigh or somebody's, just real muscular, it doesn't have to be obesity. It could be, some of you guys have some nice big muscular thighs. Sometimes we'll have to go a little deeper with the curvilinear. So the difference with these probes is that when you turn the machine on and select a probe, it presets to a certain depth by default. And it actually depends on which machine. So for instance, this one might default to 5 centimeters with this probe and default to 16 centimeters with the curvilinear. Okay? Ready to turn the lights on up here? Because I'm like holding up probes and stuff. Do you need the lights or are we good? Okay, let's go to the next slide where it says transducer basics. So you can actually tell that which kind of ultrasound probe is being used by the way it looks at the top of the screen. So at the top of the screen, it's splayed out, kind of curved. You can actually tell on an ultrasound still photo which probe it is. So the curvilinear has that very distinct curvilinear shape at the top of the ultrasound image, and that's the way the sound wave splays, okay? Versus the next one, which is your phased array. If you go to the next slide, the image shoots out kind of like a triangle, okay, from the center point out, okay? Then going to the next slide, the linear array is very flat. The footprint is flat, so when you look at the ultrasound image at the top, it actually looks completely flat at the top, okay? Are you guys still with me? All right. I can send a screenshot for someone to call the CMO. I can try to redo this if you guys are not into it because we can't see the images. It's definitely more fun if we can see what we're doing here. But this popped. So, or do you guys want me to truck along? Okay, at least for the introductory one, and we'll kind of flex from there. All right, next slide is the transducer indicator slide. So every transducer has a little indicator button on it. It's not a true button that has any function. Well, some of them do actually. Most of the time it's just a marker. And each probe is different, and each marker, sometimes they have them on both sides. You're like, which one's the marker, And so you can always tell by putting a little gel on the transducer and tapping it, and you'll be able to see yourself tapping to the top right of the screen. On the screen, you'll be able to see the indicator. But anyway, there should be an indicator button, and that matters because when we're doing patient care, the indicator should always be to the patient's right or the patient's head. So this is the indicator button on this particular one. If I'm the patient, it's going to be towards my right or my head, okay? Always right and up, just like you read a map. At least that's Army people. For Air Force, that would be north and west, okay, on the GPS. Okay, anyway, I'm just kidding. Is that funny? No? Okay. So that matters because that keeps you oriented appropriately, and likewise, it should correlate on your ultrasound machine with a little dot in the upper left corner of the screen. So if somebody starts getting kind of button happy and starts pushing buttons and they move your indicator, everything's going to be backwards. So if you're sliding the probe towards a patient's head and you just saw kidney, you should see liver, then diaphragm, then chest if you're going towards the head. But if all of a sudden it's backwards, you're seeing, the diaphragm as you move up, then the liver, then the kidney, you're like, something's not right. It doesn't correlate, right? So anyway, it's important that you're right up and your indicator button is also right on the screen, okay? Some of the machines that are portable, like the GE, the indicator buttons actually do something. Some of them are active buttons. where you can push it and it'll take a screenshot or freeze your image, or some of them will take a little video, which is pretty cool, but that's advanced and that's not on these particular machines. Okay, all right, so image orientation is the slide we're on. So this is what gets most people when they're trying to learn ultrasound, and I'll tell you, I never had blocks as a child, so this is really difficult for me when I first started ultrasound. I always wanted to know the why, and I'm gonna encourage you not to ask those questions right now. If you guys are just one of those people that you just have to know, like, why is it that when I put it here, I'm seeing the liver and the kidney, like, why am I seeing it this way? You know, we need more time for that, okay? But I'll try to give you some basics. It's mainly muscle memory. You need to know where, you know, if we're looking at the right upper quadrant, specifically what our point of care question is and what to do from there. So our image acquisition, this particular picture is a coronal view, and I'm gonna go through them. So this is where the probe indicator is towards the patient's head. I'm gonna use a face array because this is what we like to use for the EFAST. So I got this, if I was the patient, I have this right here at towards the marker towards the patient's head, and I'm on the side here, right where one would expect to see the liver and kidney interface. All right, so it's kind of posterior to the chest cavity, and if you go to your next picture, this is what it actually looks like on ultrasound, okay? Everybody with me? You guys are all seeing it? Do you guys all have it pulled up, like, legit? Okay, for real? Okay, thank you. That's confirmation. So, in that right upper quadrant, what are y'all seeing? There's a kidney shaped structure. What's right above the kidney? This is in the right upper quadrant. That little other organ, it's kind of bigger, is actually the liver. And then you can see a hyperechoic or white line where the liver and kidney kind of abut each other. And if you picture the patient's head should be to the left of the image, okay? So that really bright white stripe or line is what? If I'm going from the liver towards the patient's head, a big hyperechoic area that separates the abdominal and the chest cavity. The diaphragm, that's the diaphragm, very good. All right, and so that's the main view that we're looking at. You can see the entire kidney. You can almost see the caudal tip of the liver, but you can't see it. Caudal means towards the feet. So what we need to see is that little edge of the liver, which you can't see in this particular picture. But what we can see is the potential space between the kidney and liver, called Morrison's pouch. We can see just above the liver, underneath the diaphragm, in the subdiaphragmatic area, and we can see just above the diaphragm in the chest cavity, and that's important that you're able to see all four of those things in the right upper quadrant. If you're injured and stabbed in your tummy and you're bleeding, where do you think blood will collect first? So yeah, it's like, I don't know, would it be on the same side you got stabbed on? Well, the most dependent portion of our bodies when we're laying flat is actually the caudal tip of the liver. So a lot of people who've been previously trained at ultrasound are just programmed to look at Morrison's pouch, but if you only look at Morrison's pouch, you will miss the bleeder that's going to collect around the caudal tip of the liver or the inferior pole of the kidney. So it's actually towards the feet of the patient, towards the bottom inferior pole of the kidney is where it's going to collect first. Then after about 250 cc's or more blood or fluid, then you'll start seeing it in Morrison's pouch, and if it's even more than that, you'll start seeing it around the diaphragm, or under the diaphragm but above the liver. Are you guys with me? Okay. So this is the sagittal view. Remember, the probe marker is always towards the patient's right and up. This would be an image that I would do if I wanted to look at someone's gallbladder. I'm right on top of the patient. Probe marker is still towards the head, but unlike the right upper quadrant, I'm not over here anymore. Now I'm just right on top of the abdomen of the patient. This would also be a good view if you wanted to look at their IVC or their gallbladder, or if you're looking specific at the liver. All right, so that's sagittal. Going to the next one, we do transverse. So most of the time here, we're going to do either sagittal or transverse, all right? Transverse is what we do for bladder. We'll do two views, sagittal and transverse. We actually do a transverse view of the lungs when we do the EFAST. The E part is extended, which means that we're looking for pneumothorax. That's actually a transverse view where we're cutting the lung this direction in between two rib shadows. Okay, so that's actually a transverse view. But anyway, don't get your brains wrapped around which view you're looking at. Remember, it's just muscle memory. We're going to be practicing and putting our hands on these things, and we're going to get to practice today. So next slide is coronal. That's a view I already explained and showed you. This is the view that you would use in the right upper quadrant and left upper quadrant as part of the EFAST. All right, so now I'm on slide 24. There is an etiquette to moving the probe. okay? We can slide the probe, so you can slide it, okay? You can rock it, you can tilt, which is different than rock. Rock is more like this, and then tilt is like this. You can fan it, where you're like going all the way through. I know it looks like I'm doing the same thing, but it's actually micro movements that are totally different, okay? And then you can actually rotate all the way around the image. So that's a big deal, because if you try to do more than one of those things at one time, you're gonna lose your whole image. So micro movements for corrections, all right? Little micro movements. The next slide said fanning or tilting, and yours, when you download, does it show the videos?
Yes.
Okay, good. So that's fanning or tilting. It took like hours of my life to make this, like this little probe move on this presentation. It shows the difference between rocking, angling, rotation, and then compression. When do we use compression? Yeah, if we're gonna do like maybe, it's hard to completely compress the IVC. Like a lot of times we'll have somebody sniff, but it's the same concept. We are gonna push down on the DVT ultrasound, so we compress the vein on purpose to see if we can make it collapse. So very good, that's another ultrasound technique. So now on slide 30. So in order to do ultrasound, it assumes a few things to be truth in the universe, even though it's not totally. We assume that sound travels in a straight line. We assume it travels at the same speed of 1,540 meters per second. And we assume that nothing gets in its way to attenuate or diminish that strength or intensity of the sound. We also assume that the images don't reflect, refract, bend, anything like that. And that's all not true, right? Those things all happen. And sometimes we need that to happen in order to see distinct different tissues. Otherwise, if it all was the same, when I put the probe on a patient, it would all look like one giant liver. But instead, because the tissues are a little bit different and sound's traveling a little bit different, you can actually see a distinction with the images. Does that make sense? Okay. All right, so the next one, slide 32, is about echogenicity. Have you heard this term before? What is echogenicity?
Color?
Yeah, kind of the color. And we always compare it to whatever we're looking at to the color of their surrounding tissue. It's kind of like a CT equivalent of Hounsfield units. You guys learn about that in radiology? So that's how the radiologist looking at a CT can decide, is this a cyst or is this a solid mass? Because it's different in the Hounsfield units. Well, very similar with ultrasound, you can tell if something is more cystic or fluid-filled. Can't distinguish what kind of fluid it is, but it can tell you if it's, or if it's a stone like in this photo, which is hyperechoic, meaning it's whiter than the surrounding tissue. It's hyperechoic, white. That's because it's a stone or bone or something solid. Hypoechoic, if you guys go to the next slide, you'll see that the image in the middle is darker than the surrounding tissue. That's hypoechoic. It's less than the surrounding tissue. Do y'all agree? What might be hypoechoic? A cyst, exactly. Fluid, right? Air. These all look hypoechoic. Very good. And then lastly, it can be anechoic, where it doesn't allow any sound waves to go through it at all. And sometimes we'll see that with like gallbladder and other sometimes cystic structures as well. Even though they can be hypoechoic, they can also look anechoic, all right, depending on how much fluid is there. Next slide of 35. Is just talking about the echogenicity of tissues. Remember, one of the things I said that we assume is that the speed of sound travels through tissues at 1,540 meters per second. But that's a little different from organ to organ. The liver's a little more. Bone travels at over 4,000 meters per second. All right, fluid, when the image hits the bladder, it's going to hit through that fluid and travel more slowly in the fluid, believe it or not, than the surrounding tissue. So it matters because it changes the way the image looks, all right? Next slide is 35, reflection, all right? So some of these images will reflect, all right? Do we want them to reflect? Sometimes it's a good thing. So imagine looking in the mirror, you see your reflection, right? So sometimes in ultrasound, specifically when we're looking at the right and left upper quadrants of the EFAS, we want to see a reflection. We want to have that patient look like they have two livers, one above and one below the diaphragm. That's a reflection. And it can only do that if there's no blood or fluid in the lung. So if there's only air in the lung, you'll see two looking livers, one below and above the diaphragm. That's normal. If you don't see it, then that can indicate a hemothorax, which is bad, right? You guys agree that hemothorax would not be good? Okay, reflection. Refraction is when tissues have slightly different impedance or different, almost like echogenicity as well. And so it'll sometimes bend the sound wave, all right? I know you guys are getting lost in this. You're like, I don't care about this. Let me just put my hands on a machine. Teach me how to do it. Okay, next one is artifacts. Are artifacts good or bad, do you think? Sometimes they're good. Like if somebody comes in right over quadrant pain, and I'm like, this could be cholecystitis. Let me see if you have gallstones. I will see an artifact in there of a stone with ring down shadowing that I'm deliberately looking for to help me diagnose. Yeah, this is probably biliary colic at minimum. Is there pericholecystic fluid? All those other questions you can ask, but sometimes artifact is good. We're looking for it on purpose. And then sometimes artifact is bad. Okay, like when they asked me to come in and do ultrasound classes on people post-lunch and everybody's gassy, okay, that's bad for ultrasound. That's like the enemy. That's gas artifact, and that's not good. So they can be good or bad depending on what your clinical question is. And on that slide 38, there's a picture of a gallstone. That's a gallbladder. And you can see that sound cannot penetrate past the stone, so everything beyond that is black because the sound can't go through the stone, and it looks like an edge artifact the rest of the way down. The next one is slide 39. That's acoustic enhancement. That's when I said the sound travels through like a bladder. The bladder has a wall, and it's also fluid filled. And so it's going to slow down the sound wave as it travels through the fluid. So what it looks like, it makes it look like the posterior bladder wall is super white or hyperechoic. And that's because of the change in the tissue impedance. All right? All right, number 40. Dirty shadowing. I just told you the enemy of ultrasound is biogas, and we all have it, okay? And I don't know if you know about this, but we have this awesome grocery store in San Antonio called HEB, and I love it. Okay, whenever I move to Colorado, I'm gonna miss HEB. But our patients here have extra HEB body armor. Have you ever heard of that? You have extra armor from all that good food, and it only pays off if you're like in a knife fight, right? If you're in a knife fight, you got like 30 knife wounds and maybe not a single actual organ is penetrated, then it actually is beneficial. Otherwise, it's a detriment to your health to have that extra HEB body armor. But you bring a patient in with HEB body armor plus bowel gas, I can't see their heart. I'm like, I know they're mentating, but I'm pretty sure they don't have a heart. I can't see it anywhere. I know there has to be, capillary refill time is brisk, it says there's a heart rate, but I can't see it anywhere. And it's because it will just scatter your image, all right? So of course they have one. It may or may not be working. So next one, slide 41 of 60 is the mirror artifact. We talked about this, a mirror image. It's good. We want to see two livers, right? If we don't, there could be a hemothorax. And if this podium ever starts working, I'll probably have to restart it and reset the whole thing, but then I'll show you actual good pictures. The next lecture is much more interesting than this. Artifacts. We also look for artifacts during a certain portion of our EFAST exam when we're looking at if there's a pneumothorax or not. Remember, what are we looking at the two layers moving against each other? They're sliding, right? The visceral and parietal pleural layers are sliding, but what is that we're looking at when we're looking for that image? So in the M mode, which is motion, we're looking for seashore sign or sky, ocean, beach, but when we're just getting in between the two rib shadows, still in our two-dimensional brightness mode, we look at, some people call it marching ants, we're looking at a little bit of movement, right? That's an artifact, actually, from the two layers sliding against each other. Another use of good artifact for ultrasound, all right? Sometimes we'll see reverberations. So you guys ever see like a river or a stream or a lake, it's a sunny day and it's shining down, you see little shimmerings, okay? That's something else that we look for specifically with lung sliding, because if we see those little shimmerings or comet tails, that means that the lungs are moving, and that's good, because the image is not scattered by air, which shows no movement. Does that make sense? Am I losing some people? Hey, I get that this is less than ideal, but hey, nobody wants to make up this time later. You're already here, right? You better get up out of here this afternoon, go nap or whatever. What's your next exam? Is it the first or second Peds? Okay. You're okay. Peds 2 is a little tough. All right, system controls. You got to know how to do some basic stuff, okay? Gain, all right? Anybody that used ultrasound before, gain is a little button that we can actually adjust. It means how bright it is. And when you guys are practicing on each other, your friend will be a malo amigo and turn these things down or up where you can't see anything. So you need to know how to do some basic gain. So gain is a control, it's like the strength of the returning echoes, also known as the brightness. So you can actually adjust this. Some machines have near and far gain. All machines have just at least a gain button. And then some of them also have auto gain, which everything we have here has auto gain. So if you're putting a probe on somebody, you can't see anything, it's too dark or too white, then just hit auto gain, it kind of resets it, and then you can make your little fine adjustments. All right, our machines do not have near and far gain, and I'll show you some examples. If you go to the next slide, which is 44, okay, we see a picture of a liver and a kidney. This is right upper quadrant. I'm just going to stick with right upper quadrant so you get used to seeing these images, all right? So that is what the image should look like. I can see the entire liver in my field. I can see the entire kidney. It all looks pretty echogenic or similar, right? And everything is pretty clear. Do you all agree with me? Yeah, you looking at your slides? Okay, so that's number 44. If we go to 45, the gain is not uniform. The near field gain is too bright, and the far field gain is too dark. So you can't even tell that that's the exact same image in the right upper quadrant because the gain is off. Okay, so the machines that have two types of gain, near and far, they need to adjust both, right? They need to make the near field, which is closest to the ultrasound probe, which is towards the top of the screen, is the nearest to the probe. They need to turn that down, it's too loud, it's like it's yelling at us. And then underneath, where it's too dark, that needs to be turned up. Or in our case here, we can adjust the entire gain or do auto gain. Next slide is 48. What do you guys think? Can you guys see anything? Can you tell if that's a liver and a kidney? No, it's all too dark. And we need to turn that up. It's too soft. It needs to be turned up, okay? And then next picture, 47. Was that what I was just on, 47? Okay, it's still too dark. Number 48, what do you guys think about slide 48? Too bright. It's like the equivalent of texting in all caps, right? It's like yelling at us. Too bright. Got to turn it down a little bit. All right. The last one of 48 of 60, slide 48, that's what it should look like. That's gain that is uniform. So again, gain is the brightness, and you guys can control it. And on this machine, there's actually a gain button. It's really nice. And it's a little dial. You can actually turn dial it with your hand, or you can hit the button in the middle and it resets it to auto gain. It's pretty cool. But it does the entire image at once, not near and far, just everything at once. All right, going to slide 50. You got to know about deep or shallow. Okay, so imagine yourself in a deep swimming pool. If you want to go more shallow, you're going to go up. If you want to go deeper, you're going to go down. It's the same thing with ultrasound in the tissues. If you need to go deeper so you can see the liver a little better, you're going to go deeper down, and you push down arrows, and there's literally up and down arrows. Okay, or if you need to go more superficial because you want to see the right IJ for a central line, then you may need to go more superficial. Okay, so that kind of helps. You need to know about depth. Slide 51 shows you a picture of the liver in a right upper quadrant. Gain looks pretty good, don't y'all think? Looks decently bright, you kind of make it out. But I want to see the liver with a little more detail. Do I need to go deeper or shallower? So I want to see more of the liver. If I wanted to see more of it, like wider, then I'd go deeper. And if you guys will see on the right bottom there, there's little markers and it says 22. Do you see that? That's your depth meter, okay? And every ultrasound machine will show you that. That's depth in centimeters. So if I turn this machine on right now and put the linear probe, it'll only go down to 5. That means every little dot might be a ½ centimeter. Whereas this particular image is 22. That's 22 centimeters of depth, all right? And so that's pretty deep. So if I want to see the liver a little closer, I'm going to go more shallow. So if your next image, number 52, shows up more shallow, and you'll see the bottom right indicator marker, it says 18 centimeters of depth instead of 22. So I'm getting more shallow. I'm going up. I'm getting more shallow in depth, but I'm seeing the liver a little bit better. All right, number 53. Now I'm at 14 centimeters of depth. So when we're doing the right and left upper quadrant for EFAS, we're usually somewhere between 15, and then when we do the heart, we're around 20, depending on the patient's size. You're gonna have to make minor adjustments. All right, slide 54 is, you gotta know about a couple of modes. I told you it's a 2-dimensional machine. We mainly use here in our class 2 modes. Brightness, which is B mode, which is a default setting, you don't even have to make it there. And then the other one is M mode, where we're looking specifically for that seashore sign for the pneumothorax. So this is brightness mode, it's default. Anybody know what that is, that image is? Of? It's kind of hard, right? The gain is kind of off. That's actually a kidney with hydronephrosis. So a lot of the calyces are filled with fluid, okay? So, you know, sometimes when you first start with ultrasound, you kind of have to have an imagination. And then the more reps you have and do, then you'll be like, okay, that's definitely a kidney, okay? But we can diagnose a lot of things at bedside. I told you M mode is a motion mode. You literally by default it's already in brightness. So when I'm doing the EFAST, I'm gonna look at it in real time, see marching ants, and then I'm gonna go M mode, put a little cursor right in the middle of the pleural line, hit M mode again, and it should show you this display of sky, ocean, beach, or seashore sign, which means there's two distinct layers, right? That's the parietal and visceral pleura sliding on each other. All right. Color Doppler, I'm going to go through it really quickly. Color Doppler is something we sometimes use specifically in other exams. We're not going to do color Doppler in our class, but it doesn't tell you if something's a vein or an artery. You guys are supposed to know anatomy and know if it's arterial or venous. What you can remember though is the acronym BART. I think I told you guys that before maybe, but it means blue away, red towards. So all it does is a color indicator of what that fluid is coming towards or away from the probe. Does that make sense? So it doesn't really tell you what it is, and it's kind of like sound waves, you know, for returning echoes and stuff. And then power Doppler, we use this for low flow states. This actually amplifies the vasculature in low flow organs. Can you guys think of an example of an organ that might be a low flow state that doesn't get a lot of vascularity? Thyroid, very good. And the other one is testicle. So we could do power Doppler on somebody who comes in and we're concerned that they have testicular torsion. We can actually do power Doppler on the scrotum and compare one testy to the other, and you can actually tell. Plus you'll see the venous congestion and all that stuff, but power Doppler is used in low flow states like thyroid, testicles, things like that. And then spectral Doppler, if it's on there, that's something that's where if you're in cardiology, for those of you that are interested, they can actually tell the flow of how fast the blood runs across the aortic valve or the mitral valve, if there's regurgitation, things like that. That's what spectral Doppler is. And then lastly, the last slide, okay, 60. I know this has been a tough lecture since there's been no pictures, okay? It's definitely more fun with pictures. In order to get the best image, you have to A, kind of be familiar with the anatomy, which you all are. B, you have to choose the right probe. C, you got to know some basic knobology. And what are the three functions I taught you just a second ago that we have to know about? Gain, which is brightness. Depth, which is important. Oh, probe selection was the other one. What's that? And then being able to choose your depth of whatever organ that is, right? So some of it is by default. As soon as you select a certain probe, it'll default to a certain depth, but you do have to make minor adjustments because everyone's a little bit different. So that's how you get the best images, and really it's just practice, practice, hands-on, hands-on. Any questions about knobology or any kind of, let's take a break and let me see if I get this thing working. Otherwise we'll figure out what to do next. Okay, take at least 10 minutes.